medicine. So it is with great pleasure that I get to introduce someone who I've gotten to meet over the last few years, and it's just absolutely amazing. And it'll be great to hear from her, Dr. Aadia Rana, who's a professor of medicine at University of Alabama at Birmingham School of Medicine and a senior scientist with the UAB CFAR, where she serves as director of the Implementation and Community Sciences Core. She received her medical degree at UAB and then internal medicine residency at Case Western Reserve University and a fellowship in infectious diseases and HIV health services from Brown. Her NIH-funded research focuses on assessing inequities in HIV outcomes and care utilization, and the development and implementation of clinic and community-based interventions to improve outcomes of people living with and at risk for HIV. She is chair of the ACTG Protocol 5359, otherwise known as, oh no, the Latitude study. Good. Okay. Just got nervous, which a lot of people are aware of, which is a randomized controlled trial testing a strategy of long-acting injectable antiretrovirals with conditional economic incentives in people living with HIV with a history of non-adherence, and is also a PI or co-PI on many NIH-funded HIV outcomes and effectiveness and implementation science grants conducted in collaboration with public health agencies across the Deep South. So with that, I will turn it over to Aadia and go to it.
Great. Thank you so much, Jill and Susan, for inviting me to speak and for that wonderful introduction, which I think sets up exactly what we're planning to talk about. So my focus of this talk is on the community, academic, and public health partnerships, which I know you all at UC San Diego are also very involved in and certainly have pioneered many of the strategies that are used around the country. So we're going to take, I think, the next hour. I do have a good number of slides, especially as as Jill alluded to, the Latitude study. Susan asked me if I could maybe fit that in to this talk. So we're going to see if we have time to do that. And certainly look forward to a lot of exciting discussion afterwards. So really appreciate the opportunity to share this work. So we're going to do a brief overview of the HIV epidemic in this country and the initiative itself. And really, most of the talk will be on the work that's ongoing in Alabama by a lot of the colleagues, community public health agencies. Certainly, I'm not going to be able to include all of the work that's going on, but just some of the ones I wanted to share with you all. And then time permitting, some of the Latitude study results for discussion. So as all of you are very well aware, HIV continues to be an epidemic in this country with over 1 million people living, over 700,000 deaths since the beginning of the epidemic. We are starting to see a little bit of a steady decline, but still close to 40,000 new infections per year. And I think the thing to emphasize is even with these declines, we're continuing to see a disproportionate impact on certain populations, particularly racial ethnic minorities, gay, bisexual men, and other men who have sex with men, and then the regional disparity. So the South accounts for half of all new diagnoses, despite making up just a little bit over a third of the population. And by incidence rate, 8 of the top 10 states are in the South. And women of color in the South are particularly disproportionately impacted, where latest data indicates that Black women accounted for about 6 in 10 of all new HIV diagnoses among women, despite making up less than a quarter of the population. And so the HIV care continuum has been fair to stagnant. This is the latest data that is available from the CDC that shows that while about 87% of people living with HIV are estimated to be aware of their diagnoses, our biggest drops really happen when we talk about retention in care. So only half of people are regularly engaged in care. This definition being having a visit with a CD4 or viral load every 6 months, separated by 60 or 90 days. And then only 57% of people living with HIV, either aware or unaware of their infection, are aware of or achieve that goal of viral suppression. And when we compare this to other high income countries across the world, we're sort of dead last in that way. And I think trying to understand all of the factors that influence that figure are important to all of the work that we are doing. And so kind of really trying to understand who is it and where are they, the people who are having these challenges. And so this is the care continuum with the black bar being total, but then sort of dividing it among other vulnerable populations, such as younger age, race, and mode of transmission. And as you can see across the board, certain populations, including youth and Black African Americans, and particularly males with injection drug use as their primary transmission, have lower achievements on the care continuum all the way across. So things that could certainly inform our approach to ending the epidemic. But of course, this is, cross-sectional. This is a point in time. And engagement in care is dynamic. And so this study by Kim Powers at UNC, actually really interesting. She used data from the North Carolina Health Department, all newly diagnosed individuals between 2006 and 2015, and followed them up longitudinally, using CD4 and viral load as a proxy for engagement in care. And these about 16,000 patients, she wanted to classify what are their patterns of engagement in care. And so they defined HIV care attendance in each 3 and 6 month interval after diagnosis, using the labs as the visit care proxies. And as you can see, about a quarter of people after diagnosis got in care and stayed in care. About another quarter of people never really regularly engaged in care over this longitudinal part. And then you have the folks kind of in between, where they either early engagers and then declined, and then others who are either early increasing and late increasing. And in their analysis, using, again, only the data that's available in surveillance, older age at diagnosis was protective against all of the suboptimal trajectories, and MSM status was also protective. But there's only so much we can ask of surveillance data, and it's really important for us to try to contextualize these patterns as we try to develop these targeted interventions. So the social ecological model of HIV risk and vulnerability in the U.S., I think this kind of spells it out, but we implicitly understand that there are multiple levels that inform the outcomes of the patient who's standing standing in front of us in clinic. And I think a lot of the clinic-based or interventions that we perceive usually are related to the individual level factors. So things like mental health or substance use, and social determinants of health, such as unstable housing or a history of criminal justice involvement. But we also have to consider things like network level factors, like what is the HIV prevalence or syphilis incidence in a person's network, or the rates of acute and recent HIV infection. Certainly community level factors, the stigma not just of HIV, but of sexual and gender identity, poverty, racism, what level of services are available at the community level, and policies such as needle and syringe exchange. And then you have the social and structural level factors. Whether are you a Medicaid expansion state or not? What protections are available for gender and sexual identity, and availability of healthcare services, including cost. And then our broader sort of milieu to understand is what is the epidemic stage, kind of what is the prevalence, the population levels of viremia, as well as the and force of infection.
So Aadia, there was just one thing I was looking on the slide for it. I didn't see it, but I could be missing it. I just always want to point out minority stress as being a really big part of this. And it's probably captured by some of the other things you're saying, but just that notion of, the high levels of stress that, these individuals face. Anyway, that's all I just wanted to add. Sorry about that.
No, sure. I think certainly, and I probably should have clarified. This is definitely not all encompassing,
Right.
and all of this should be contextualized to your community as well. So everyone should be able to adapt all of these factors, I think, as it relates to their local context. But I think great point. Thank you, Jill. So the Ending the Epidemic initiative, I think, kind of crystallizes this idea that we have evidence-based tools, including behavioral interventions, structural interventions, and biomedical interventions that have been shown to impact both HIV incidence as well as HIV-related outcomes. The challenge has been, as we all know, implementation. And how can we effectively and comprehensively implement all of the tools that we think we have at our disposal. And so the successful pathway certainly takes into consideration the local context of all of the key stakeholders. I think this includes the expertise of the academic partners, or the sort of the knowledge, the scientific knowledge that is available, and the methodological expertise, the mission and the mandates of the public health institutions, and then the involvement, the knowledge, and the collaboration of the community partners. And this includes people with HIV, our community and municipal policymakers, care delivery organizations, and just overall communities impacted by the epidemic as well. And so the initiative, as you all know, it recognizes that there is that disproportionate impact on certain populations, particularly racial and ethnic minorities, and then the sort of geographic differences as well. So the initiative prioritizes the 48 most impacted counties, and then 7 states, and they chose those 7 states based on their significant or substantial rural HIV burden, and Alabama is one of those. So in Alabama, just to share for those of you who may not quite be familiar with this state, so we're a state of slightly less than, or maybe right at maybe 5 million people. Our largest city is in central Alabama, in Birmingham, and capital is slightly to the southeast, Montgomery, and next largest cities actually now Huntsville in the north, and then Mobile on the coast. And so there's about 17,000 people estimated to be living with HIV in our state, with the concentrations primarily in the urban regions, Birmingham, Montgomery, and Mobile, but also this concentration along sort of the mid-south area, in this area known as the Black Belt. And it's known as that because of its very rich, fertile soil. So it's a very agrarian, rural society, like rural area, but also, even with its lower population, still has some of the highest incident rates of HIV and prevalence rates in the state as well. And it actually experiences profound health disparities of many stripes. And that includes, cardiac and oncologic, including HIV outcomes as well. And so our incidence, prevalence, and death, since this is the last report that's available in Alabama, is looking at sort of comprehensively in this way. Our incidence rate is anywhere between 500 and 600 new cases per year. That's been fairly stagnant, maybe a little bit of a drop just this past year. But the one thing to point out is a lot of significant health disparity. So the newly diagnosed HIV rate among Blacks and African Americans is nearly 3 times the overall state rate. And among Black males, it's 8 times that, among whites, and among Black African American females, 9 times compared to white females. And so this is our care continuum from 2022. So 86% statewide are aware of their diagnosis, but we sort of mirror a little bit of that care continuum. And this is a diagnosis space. So these are all of the people who are aware of their diagnosis. 54% are retained in care, and only 61% had a viral load less than 200 at their last check in 22. And in addition, when you look at another marker, which is the PrEP to need ratio, Patrick Sullivan and his colleagues developed this marker using the number of PrEP users divided by the number of new diagnoses in that same year. And Alabama was one of 3 states with the worst PrEP to need ratios. And that ratio was much, much worse when you looked at it by race or ethnicity. And so with the disparity in Alabama, whites had a PrEP to need ratio of 11, and Hispanics worsened to 8.23. And then when you look at Black and African Americans, we are less than 2. So this is the context of the work, or sort of where we are working, and some of the data that we need to help drive and inform our work. So to start, some of the collaborations that I'm going to talk about later on with our projects, the Birmingham Unite started as a collaboration with the UAB Center for AIDS Research, the Public Health Agency in our county. Jefferson County is where Birmingham is located, and then the Jefferson County Health Department, as well as the care organizations in our county. So that includes our UAB 1917 clinic, the UAB Family Clinic, and then the AIDS service organizations. And we were having a lot of challenges with people who had been diagnosed but were not being quickly linked to care or effectively linked to care. And so the Jefferson County HIV/AIDS Community Coalition was formed, which allowed all of these partners to meet on a regular basis to really think about processes to allow almost sort of a health information exchange, led to the development of a universal release, enhanced tracking to inform service delivery to address gaps in treatment cascade. This regular meeting of these partners allowed also for the application to a shared application to funding opportunities, CDC prevention grants, where so it wasn't just one entity receiving it, but a shared funding opportunity using some of the work that had already been foundationally done by the coalition, and really trying to integrate service delivery across our agencies. As we all know, very fragmented care in terms of healthcare delivery, not just for HIV, but across all care deliveries. And we did see a reduction of new HIV cases in Jefferson County following this. Can't say this is what happened, but can't imagine that this did not have some sort of impact in this way. And so just want to illustrate some of the work that really led to these regular meetings, frontline provider meetings, including an Ending AIDS meeting, the submission, as I mentioned, of 2 CDC high impact prevention grants with the UAB Center for AIDS Research in a supportive role to provide technical and methodologic evaluation assistance. And around the same time, we have this formalization of the Alabama Regional Quality Management Group. So what this is this is a consortium of all of the HRSA Ryan White funded clinics across the state. And it has a focus of quality improvement with quarterly sharing of aggregate data, best practices, and they convene in Birmingham. UAB CFAR hosts the meeting, and all of the Part C and some of the Part B agencies who provide care come as well. And this map, the stars are all of the different AQMG clinics, with the circles representing their mobile or telehealth services that are provided. So across the state, the AQMG certainly has a very comprehensive reflection of the people, of the services provided for certainly people living with HIV, but also people who are at risk for HIV. And so in 2017, using the recently released UNAIDS 90-90-90 initiative released in December 2015, we formed the Ending HIV in Alabama Scientific Working Group. And really, at that time, it was to support the development of and implementation of research really focused on the 90-90 initiative, led by investigators with expertise in this area. So really trying to leverage established services and scientists from all of the different cores in our CFAR, really to focus on innovative research in Alabama. And we wanted to answer fundamental questions about HIV care in Alabama, what aspects of our approach to HIV prevention and care are effective, what populations are not being served sufficiently or at all, how can we comprehensively yet also cost effectively improve access to and engagement with HIV care and knowledge of services available. And then also, I think, and most importantly, what broad community assets, resources, or programs are necessary to achieve these goals. And so with this SWIG, we were able to fund a number of developmental grant awardees focused in this area. So we have people who are doing trying to use big data science to estimate undiagnosed HIV infection and inform testing interventions in Alabama. And that was Dustin Long, along with Lynn Matthews, Samantha Hill, who was did her adolescent fellowship and focused in on HIV. Got a pilot really looking at parental support for PrEP use among adolescents, and that informed that development grant resulted in her K Award in September of 22. And then Matt Gravitt, we are a predominantly rural state. And so how can we leverage methodology such as crowdsourcing to inform prevention services for MSM among the Deep South? And Libby Van Gerwen received a developmental grant really focusing on attitudes and beliefs on HIV risk and pre-exposure prophylaxis among transgender women in the Southeast. So the SWIG negotiated and procured both commercial and surveillance data sets. We do need a very data-driven approach. We have disjointed health systems and multiple sources of data. And so we wanted to support investigators to inform their approaches with available data. So we were able to, in collaboration with the 1917 clinic, purchase commercial data from Quest and LabCorp, which included HIV, STI, hepatitis, and also substance use data, which basically covered the state of Alabama. And so these included, of course, test results as well. And then also surveillance data, which includes results of HIV testing as well as STI testing. And then we worked with Alabama Medicaid to have access to claims data. And so this is sort of a service that the SWIG and now the implementation community sciences core can now provide, is that investigators can access and request data from these data sets in order to inform their grant applications or their projects for ending the epidemic initiatives.
Aadia, what about MPOX? I didn't see it on the list. Was it too early?
Too early. Okay. This data request includes data through 2020.
Yeah, I meant recent was the word I was looking for.
Yes, not that recent. Yes, right.
Okay.
Yes, maybe in the future with future negotiations, although these data sets are not cheap. So I'm not sure, but
yeah.
But
and Susan has another question: what the level of geographic resolution was available in the data purchase?
Yes. So 5-digit zip code was available. So we aren't able to, I will share, we're not able to link. So in the Quest data set and the LabCorp data set, we do not have, there's no linkage all the way across, right? So we don't have identifiers of that nature. We only have a 5-digit zip code. In some cases, and I don't have the proportion off the top of my head, we don't have the patient's zip code. It ends up, what got provided was the provider zip code. So it's not, with all of these data sets, it's the quality can sometimes be, you have to have some of these caveats. But between those two agencies, and then coupled with the surveillance data, I think the idea is to try to incorporate all of the information that we have potentially at our disposal to inform some of these interventions. The other thing the SWIG innovated were these opportunities for a community funding grant. So this also leveraged 1917 Clinic, our HIV clinic, which serves 3,600 people living with HIV in the state. They're 340B funding. And so these are, it was really EHE. So even though we developed the SWIG under the UNAIDS initiative, 2019 with the EHE initiative, it really provided this unique opportunity for us to try to be entrepreneurial in our approach. Federal agencies must work together. So we worked with the 1917 Clinic to create this funding opportunity for community organizations to submit based on the diagnosis and treat pillar. The 340B money still needs to be used for the population that the clinic is, funded for, right? And so what would happen is community agencies apply using concept proposals addressing the diagnosis and treat pillar, and then as part of that process, they are paired with a CFAR investigator to work with them on technical assistance, methodology, and evaluation, essentially, because HRSA still, of course, requires an evaluation report, as it were. But this collaboration really allowed that partnership to develop between the CFAR investigator and then the community agency. And of course, it came with that funding opportunity for them as well. And these were one-year pilot grants that were offered to the sites. And so we've been doing this now since about 2020 and have funded a number of organizations and established relationships that have resulted in EHE supplements and other grant funding opportunities between the CFAR investigator as well as the community-based agency as well. And we're in the middle of our next round right now, and we're really excited. We had 6 community organizations submitting concept, some of whom are not your traditional AIDS service organizations. They want to partner with an AIDS service organization, but really trying to broaden the reach, I think, of opportunity for both prevention and testing and linkage services as well. I think we had 6 submit. I believe 3 or 4 were greenlit for application development, and their CFAR collaborators have also been assigned. So we're really looking forward to the next steps. And so I just want to highlight a few of the investigators that are working. So Dr. Letitia Alopre, one of my colleagues, is looked at HIV preferences using a discrete choice analysis methodology, specifically among African-American women in the rural South. And in that, she found that this is before COVID and before, I think, the widespread availability and understanding of telehealth. So that, at least for Alabama. So this is with that caveat. But the majority of these women in these rural areas really prefer to have their visits in a doctor's office at the time that this study was conducted. And then also in terms of their preference with regards to medication form, more women reported preferring a long-acting shot or a pill versus implant or vaginal ring. So, and I think for this project, she partnered with, at that time, a community organization based in Montgomery that is really positioned in the Black Belt. And so to successfully enroll and engage and get 304 women, African-American women living in rural Alabama to participate in the study itself was quite an accomplishment. And then, of course, with the findings helping us direct some of the future work in this area. Lynn Matthews used the data sets that the SWIG had procured to really develop a sort of data-driven, community-engaged mobile testing initiative in rural Alabama. So overlaying some of that data to identify cold spots with low HIV testing rates and potentially higher HIV or STI incidence rates. And then so she worked with the same community organization to develop this initiative where a mobile approach was used after in-depth interviews and rollout to scale up to inform scale up as well as dissemination. So we have partnered with 3 state health departments in the Deep South to really try and understand, you know, we know that we have these challenges with both, linkage as well as engagement and viral suppression. But we wanted to really understand where this is happening and what are the sort of factors that are informing this, and how can we really understand this at more of a population level within our states. And so we formed this collaboration with Alabama, Mississippi, and Louisiana Health Department. It was R01 that was obtained in 2018. And we wanted to look at the time to viral suppression and the geographic differences in that in each of these states. So we use time to viral suppression kind of as an indicator, capturing all the collective effectiveness of HIV prevention, from testing to linkage to ART delivery and all of the support services as people move across the steps of the care continuum. And we had already demonstrated, even just within Alabama, there was very dramatic geographic variability in time from HIV diagnosis to viral suppression. And we wanted to see if we could, in some way, understand any of the drivers of this heterogeneity. So our first steps were really partnering directly with the state health departments in these 3 states, and we conducted retrospective population-based cohort study. All of the persons over the age of 13 with newly diagnosed HIV from 2012 to 2019. We used the Enhanced HIV/AIDS Reporting System, EHARS, which is a standardized document-based surveillance database used by all of the state health departments. We developed a common data structure across the 3 states. Detailed analysis protocols and statistical code were developed by us, by our study team, but in collaboration with the health departments. But all of the analysis was conducted at the health department. And the health department then transmitted summary statistics to us, where they were combined using meta-analytic techniques. We used a Kaplan-Meier method to describe time to viral suppression by year of diagnosis in each state. And we used 2012 to 2015 and 2016 to 2019. We chose these time periods really to reflect the changes in national treatment guidelines that supported universal test and treat, as well as the shift to full integrase inhibitors as a class in first-line regimens, which do have a faster time to viral suppression compared to the other classes. And in addition, in mid-2016, Louisiana became the only state of these 3 states to expand Medicaid. And so we wanted to kind of assess potentially the impact of that. And we then conducted state-specific meta-analysis of Cox proportional hazard models to examine associations of any of the factors in the surveillance data. So we had a total of 16,000 or almost 17,000 people included in the analysis, 3,600 in Mississippi, 5,000 in Alabama, 8,000 in Louisiana. And across all 3 states, approximately half of new diagnoses were in that 25 to 44 range, and 75% reported male sex at birth, and 70% identified as Black race. And the primary method of transmission was MSM in slightly less than half, and 30% reporting heterosexual transmission. And in all 3 states, the proportion of those with CDC stage 3 or higher did not change significantly between the 2 time periods. So just to go quickly, starting with Mississippi, in the earlier time period, 2012 to 2015, we have a median time to viral suppression was 331 days, less than 30% achieved viral suppression in 180 days. This improved to a median time of 168 days, with still almost 50% only achieving viral suppression. In Alabama, our median time was 211 days, with just 40% achieving viral suppression within 6 months. That improved to 135 days, and now we're closer to 60% achieving viral suppression in 6 months. And then finally, Louisiana, that was our most populous state in our sample. And in the first time period, had a median time to viral suppression of 241 days, with only about 30% of the people achieving viral suppression. And we had our most dramatic change here, with over 60% achieving now viral suppression within 180 days, and a sharply reduced median time to viral suppression of only 118 days. And of note, Louisiana is the only state of these three to expand Medicaid, as I mentioned earlier. In our analysis of variables, just that those that are available in the surveillance data, our findings really confirm previously predicted reporters of outcomes across the care continuum, namely younger age, male sex at birth, non-white race, and non-MSM transmission were associated with longer time to viral suppression, while presenting with advanced or symptomatic disease at diagnosis was associated with shorter time to viral suppression in both time periods. So looking at this sort of geographically by the two time periods, you can see 2012 to 2015 and 2016 to 2019. The bluer you get is the longer time to viral suppression on these maps. And you see an improvement all across the three states, both in terms of time to viral suppression. What we also wanted to look at was the social vulnerability index. We added that to these maps. So the social vulnerability index is a CDC variable which ranks each census tract based on social factors, 16 social factors, and groups them into 4 related themes: socioeconomic status, household characteristics, racial and ethnic minority status, housing type, transportation. And so, as you can see here, while we did overall have a general improvement in all of the different just time to viral suppression sort of across the board, there's still areas that significantly have still a much longer time to viral suppression. And the census tracts that are highlighted within the counties are the census tracts that have that much higher rate of social vulnerability index. And we wanted to share this with our health department partners to show, okay, this is where you guys have improved and it's going really well, but here's where we're continuing to have some of these challenges, and are these potentially informed by the same factors that we're having to track, and could that inform what the type of interventions you would need to conduct in these areas. And we also superimpose that with the HIV care clinic or HIV care that's available. And so in areas particularly that have the longer time to viral suppressions, and are also in those high social vulnerability index areas, could this be priority areas for health departments in their statewide Ryan White programs to particularly prioritize? And so our goal in the product of this analysis is actually a rapid start manual for health departments to really target areas for intervention and support. We've convened our community agencies and the HIV clinics and public health departments for 2 meetings now in the development of this rapid start manual, and are looking forward to having that developed and published soon. And so I think one other brief reflection in terms of what the successes of the academic public health partnership. So our Louisiana epidemiologist actually suggested this analysis looking at the impact of redlining on time to viral suppression. So if you're not aware, redlining is sort of the term that's used for a federal program by the Homeowners Loan Corporation, developed in the 1930s, which classified residential neighborhoods by their investment risk, as essentially. And And those that were labeled as D or red areas were poorer, predominantly Black neighborhoods considered hazardous. And so then that got termed as red line. And so, that was a very racist, structurally racist policy. And what is the impact of that policy even now, or is there an association for those areas that had been previously redlined among those who are now being diagnosed with HIV? And so we had the data on redlining for 2 cities in Louisiana, New Orleans and Shreveport. Just to summarize, this was presented at Croy last year, and manuscript is under review, that in fact, we still saw generational inequities in terms of time to viral suppression in people who were diagnosed in communities that were redlined back in the 1930s. And so the health department, with this information, really wants to try to target people who are diagnosed in these areas in terms of the supportive prevention and linkage services. This work has also allowed us to successfully apply for another RFA, looking at this light VS, a limited interaction targeted epidemiology on viral suppression. So the RFA was to support HIV epidemiology research, establishing large digitally maintained cohorts in really to prospectively investigate trajectories of HIV care engagement and viral suppression, as well as temporal antecedents and multi-level predictors of changes in care engagement and sustained viral suppression. And so we thought, we've established these relationships with these state health departments. They are the ones who know who's engaged in care, who's not engaged in care, and also have processes of data to care and data for care in their public health departments. And so could we use them and partner with them to recruit participants into this cohort? And so we are underway. So aim 1 was to develop an app-based recruitment and enrollment tool, particularly targeting individuals who have non-sustained viral suppression, who've been diagnosed for at least 12 months, or who have been not engaged in care. And then we will follow them longitudinally and conduct annual baseline and then iterative psychosocial survey assessments collected via the app, and then look at outcomes abstracted from state EHARs and surveillance data. And so we're actually looking forward to our first enrollment occurring on Monday in Louisiana. So stay tuned for some of those results as well. And then lastly, I just want to touch base on a project that we started working on now a couple of years ago with the Mobile County Health Department. So it's in the coast. That's about a 4-hour drive from Birmingham. And the Mobile County Health Department, while they were a member of the Alabama Quality Management Group, they weren't very involved. They usually did not come in person to Birmingham. And even though it's a high incidence and prevalence area of the state, the UABC-FAR had not very successfully engaged this agency itself. And luckily, they reached out to us and said, hey, there are these funding opportunities. Do you think we could participate with you? And, you're like, whoa, you want to work with us? Yes. How can we make this work? And the Mobile County Health Department, it's unique. So it's a health department. So it provides, prevention, DIS services for those who are tested or doing testing very actively, but it also has a federally qualified health center. So it receives Ryan White Part B and C funding. In our fragmented care delivery and impossible data sharing space, really this unique opportunity to implement and have access to data in terms of both clinical and population level outcomes. And so we were really thrilled about starting this project. And in addition to, our overall outcomes in the state of Alabama, Mobile had actually had an increase in its HIV incidence between 2015 and 2019. So certainly a priority to work with. And so one of our first steps was, since we were doing a combination intervention for testing linkage and rapid start of ART or treatment, we wanted to develop that process map. And so I think this was actually the first time everybody on both sides of the prevention and treatment table sat down and thought of all of the different scenarios and all of the different ways people can get linked to get tested, then linked to the DIS, and then linked to care. And so it took several rounds. I don't know if anybody's used the Miro board before, but it was actually very helpful, this online tool, to develop these process maps. And so we kind of use this as our foundation and then continue to add on and edit as we change moving forward. So our first of the combination intervention was to do data-driven testing. So Lynn Matthews, who's a co-PI with me on this project, using some of the work that she did in Mobile, in Montgomery, using the commercial data sets to really identify those cold spots again. So again, using Quest and LabCorp to identify the testing coverage and testing sites, and then using surveillance data to look at STI incidents in order to identify the priority areas with geospatial mapping. And so the areas were identified, and 4 individuals from Mobile County ranked each zip code testing prioritization from 1 to 3, with 3 being the highest priority. And these are some of the maps that were generated. So this is again by zip code, and then overlaid with the HIV positive screen by density, as well as the syphilis positive screens. And so we're in the process of now the priority areas have been identified, and we're starting to roll out the actual mobile testing and testing strategies for those particular priority areas. The second intervention is to do field administration of the Prepare tool. Those of you who work in FQHCs, the Prepare tool is a 17-item questionnaire gathering social determinants of health, such as unstable housing or food insecurity. And our goal is to try to assess those as soon as possible. So field testing at the time of diagnosis, and then that information will get transmitted to the referral clinic. So rather than waiting for the intake visit to collect all of this information, in a brief, prioritized way to see if we can collect this information in the field at the time of testing. And then rapid ART. And so Mobile County had one of the longest times to viral suppression in the state. And so we have started working with them on this process of implementing Rapid Start first in their clinic, which is the largest HIV clinic in Mobile County. And they started in December, late November, early December. And so they're rapidly underway on their Rapid Start program. And so I'll just finish with, this is why we're doing this. So when I was on service in August of last year, these are just a few of the cases that we saw in the two weeks that I was on service. And so we're having people who are still presenting very late at the time of diagnosis. We have people who are aware of their diagnosis and not engaging with care. Certainly considerable mental health issues and substance use issues. And then a particularly unfortunate case of a woman who probably seroconverted sometime during her pregnancy, did not engage in care, and so had been tested first trimester and was negative. And though there had been some information collected suggesting she could be with a partner at risk, unfortunately disappeared and was unable to be located, and then presented essentially at delivery. There was a missed opportunity for testing when she presented during 3rd trimester for a sick visit, but HIV testing wasn't done. And unfortunately, there was transmission to the infant during this delivery. So these are the reasons why we need to do this work. And again, I did not comprehensively cover all of the many exciting and ongoing projects that reflect just these important public health, academic, and community partnerships. But certainly, I what I've shared is for us, and maybe for you all as well, this is the only way it's going to happen in our state, and really centering a lot of our work with the public health agencies and the community agencies. That is the direction that our CFAR and our work is certainly going to go as we try to impact this epidemic in Alabama. And I don't think, I'm sorry, Susan, I don't think I have time to go over
I will survive.
latitude. Is that okay? But I'm happy to answer any questions or share and, share slides or come back again and talk.
I was about to say that one. Then we'll have you come back maybe in person.
Absolutely, absolutely.
Susan, do you want to lead some of these questions? Because I know that you and Tom have a few things and no.
I can't hear you. I can't hear what you're saying. I don't know if you're cutting out or I am.
Can others hear me? I think I'm normal.
Yeah. So can I ask? Oh, I've got such reverb. Hold on.
Well, while she's doing that, Tom, Martin, do you want to unmute? I don't know if your first question was the same as what Susan had asked before, because you're both using the word coverage and resolution, and I'm not sure. I feel like these are big data words that I don't know if you're there and you can unmute yourself, Tom.
I can unmute myself.
Great.
But I'm bicycling up a hill.
Then that is not good.
Just give me 1 second then. So
Can
the question, yeah, go ahead.
Can you hear me now?
Yeah.
Okay. So I guess I have two questions. One in the heat map of high burden, meaning higher rates of, I believe it was unsuppressed, lower rates of suppression, whatever way you want to say it. It looked like the health centers were not superimposed on those areas, like kind of consistently. And I just wondered if that was true or I just looked at it too fast.
So let me see.
While you're looking, that kind of coincides with my question as well. So I might as well just ask, it's what kind of coverage did the LabCorp and Quest data have for the state? What proportion of tests does it cover?
Okay, great. Susan, is this the map you're talking about?
Yes.
Okay, yeah.
Just seeing a lot of dark blues that don't have a red dot close to them.
That is right. That is exactly right. And what the and I will share what I don't have. So all of these red dots are physical. They are physical clinics.
Right.
I don't have represented here. Some of these clinics do some telehealth in those areas. So I don't have that accurately represented here. These are only physical clinics. So I think that's a great point. And something, again, information for us to provide the health departments, right? To say, this is what's going on. So I think that's exactly right. And I think we were actually surprised when we had our last sort of rapid start manual meeting. The Mississippi coast was particularly continued to have a much darker time, a longer time to viral suppression with these darker colors, despite having, a lot of clinics in the area too. And it was very interesting to us because the health department was puzzled by that too. They're like, well, why is that happening? We're like, well, we don't know, And so really, I think this information is so important to have this quaddirectional conversation, exactly that. Here's the challenge though, when we do, and I didn't have time to share all of that data, but when we ask patients or sort of those as key stakeholders, could we build a clinic in your area, or is your drive time the issue? The stigma is still so high that answer often ends up being no, because, auntie might see them walk into that clinic, right? And so if it was going to provide HIV services, it would need to still be in a very nondescript, it's not only an HIV clinic way. In particularly, a lot of these dark blue areas that you're seeing, these are very rural counties. And even in Louisiana. And so something that's why that community input is so important as we consider our next steps for the intervention. So absolutely.
Yeah. And just one more, and then I'll stop. I can't see who else has their hands up, but one thing that I've been sort of curious about is, the goal of ending the epidemic is reducing incidence, yet we don't really measure incidence. And one question I've had is, what would be the merit of encouraging health departments to record negative test results and, potentially just hold on to it for, 18 months and then cycle through. So it's not just forever and ever, but at least then you could see people who seroconvert within a 1-year time frame. Has that
Yes,
discussion come up at all?
it has, and we had it in some ways where anyone who received a free test, any agency that received test from the health department itself, so the Alabama Department of Public Health, had to record the results of that test, whether positive or negative. So that does not include the LabCorp and the Quest and all of that, but any of the tests that were provided by the state had to be there. We're like, that's so great. We're going to incorporate that in our data sets. You know how they say data is garbage in, garbage out? It was all garbage. The information was not reliably entered. Dates sometimes didn't match up. Negative dates were put in on date after the testing had occurred. It wasn't reliable. So I think that would be good. I think Jason Halperin is on the call. I think they were very close to doing that in Louisiana. I believe the community had a lot of input on that. Jason, I don't want to misspeak, but I feel like there was a challenge from the community who felt that it would be stigmatizing to collect negative tests. And so I don't know where they fell, but yes, I think opportunities like that, but it will probably require a lot more engagement and input from the community.
Go ahead, Jason.
Yes.
Yeah, I could jump in, and Aadia first. This is such an incredible presentation and so much we could learn from your coordination and use of data and having multiple stakeholders. I also want to just highlight, you said it, but I cannot stress enough from working in Louisiana, Medicaid expansion. I mean, I feel like if there's anything we should walk out of here as advocates, it is to make our voices heard about universal Medicaid expansion. You are correct. We really pushed for negative testing. I was one that really advocated for it. We were really looking at missed opportunities. We had a nice plan throughout the Louisiana Health Department that we would look backwards from a positive test result to see how many times someone touched the health system and didn't have negative testing, and then kind of use negative testing. There was real pushback from the community. There was just so much concern, especially with some of the trends in the South of stigmatization around LGBTQ and transgender health. There was a lot of, we don't trust the government. And that played a major role in us not moving forward with capturing negative testing results.
Thanks so much. I guess I'm just going to push on this one more time. Do any of the commercial sources of data record linked negative tests? Could that be purchased and thus looked at in a de-identified way?
Linked negative tests, what do you mean by that, Susan?
History of a negative followed by.
Okay, so I will say that, yes. So we were able, because they have their own patient identifiers, right? Like whatever that number is. So we were able to see if a person had a negative test, but only if they were tested within LabCorp, not if they were also tested within Quest, not if they were also tested at the health department. So we don't have that kind of linkage. Oh, what a dream. What a dream. That would be amazing. And then Tom, I want to make sure I answer your question. You were asking about the coverage of the LabCorp Quest data.
Yes.
Yeah, for your state, what kind of proportion of HIV tests does that cover?
Yes, so it really depends on the region of the state. So anywhere from the Black Belt north, which is the majority of the state, LabCorp and Quest, I think provided we estimated about 60% to 70% of the testing that occurred. Further south, unfortunately, there was a lot of private labs in the area, and a lot of the states and clinics contract out with other labs, or like the institutions themselves do the labs. So not as thorough in that way. The one thing that we did have statewide across the board were all of the positive STI testing and HIV testing. And so that's the more reliable, but overall, we felt in terms of representative, I mean, nobody had ever looked at any negative testing data before for our state. So even with this, not 100% coverage, it was very informative. All of this data has been shared with the AQMG group. So all of those clinics that provide prevention and care services. And so they have shared with us how they have used some of this data to say, okay, we're going to direct our testing here, or we're going to do that there.
I'm just keeping an eye on the time. Unfortunately, it's just past 9 o'clock, and a lot of people got to get to other meetings and clinic. This was incredible, Aadia. Sorry, I know Tom had another question, and maybe the two of you can chat separately because he had a second question. But thank you so much, Aadia. This was incredible. We are going to hold you to coming back.
Yep. Yeah, I just also want to say thank you so much. That was a great presentation, and we know where you live. We'll find you.
I'm happy to. And I'm happy to join the adherence. Is that right after this? If you
Yes, it is.
Okay, and I don't have a link to that, Marvin. So if you can send
just stay on here.
Oh, stay. Okay, I'll stay.
And just for everyone, we're off next week in observation of Cesar Chavez. So you get a week away from us. And then April starts our CROI series, April 5th, with Dan Lee on complications of HIV. There'll be a calendar invite for that shortly from Marvin, or, the agenda. Anyway, thanks again. Enjoy the adherence talk for those who are joining. Bye all.
Thanks, everyone.